Alright, so I'll be covering, I'm Michelle by the way, I'll be covering essentially like lower limb. So I figured probably a good place to start would be at the inguinal ligament, and just work our way down from there. Inguinal ligament canal, was that covered in the abdo one?
Vaguely, I think.
A bit, yeah.
Okay, alright, so the inguinal ligament itself, I mean, in terms of its attachments, will go from the ASIS down to the pubic tubercle. I guess the importance of just knowing the pubic tubercle versus, say, the pubic symphysis or the pubic crest is because when it comes to two definitions which are clinically relevant, you have the mid-inguinal point and the midpoint of the inguinal ligament. And they sound really similar, but they're actually used, I guess, anatomically for different landmarks. Right? So when you're talking about the midpoint of the inguinal ligament, you're essentially going, and you can actually feel it on yourself or on patients. And if you have someone thin, then I guess it's clinically relevant. Once, if they're obese, then it all goes out the window. But the midpoint of the inguinal ligament, you're essentially measuring halfway from the ASIS to the pubic tubercle. That is where you're going to essentially feel the deep inguinal ring, right, which is clinically important in the context of hernias. So if your patient's lying flat or whatever, if you occlude there, and then you ask them to cough and so forth, and you have a bulge coming through, then that's your your inguinal hernia. Yeah, now, so that's the midpoint of the inguinal ligament, right, which is different from the mid-inguinal point, right? So the mid-inguinal point is halfway from your ASIS to the midline, your pubic symphysis, right? And you guys know what that's used for, mid-inguinal point? Yeah, the femoral pulse, yeah. So, so that's the difference. I just thought maybe I'll start with that because they sound the same, and I guess if you're specifically, then you know that that's what they're trying to do, maybe trick you out on that definition. So with respect to the inguinal ligament itself, it's formed by the inrolled edge of the external oblique aponeurosis, yeah, which is, I guess, your most superficial anterolateral abdominal muscle. So I won't waste time trying to find a photo of it, but so with respect to the external oblique muscle, it's running downwards, pointing medially. The most inferior aspect of it is just that fibrous fascia, that aponeurosis. Right now, as it moves most inferiorly, it rolls kind of in like that, right? And then that is essentially all the inguinal ligament is. Okay, it's forming the floor. The inguinal ligament is forming the floor of the inguinal canal. And as we already mentioned, the inguinal canal, right? If you wanted to know exactly kind of where it is or its general anatomy, you know it's going to start, or you know it's going to be located above the medial half of the inguinal ligament, right? Because the inguinal canal will originate at the deep inguinal ring, and we just mentioned how to identify that, yeah? The midpoint of the inguinal ligament. So from there, right, it runs, the inguinal canal will run inferiorly and medially, and then open at the superficial ring, which it doesn't really show it too well here, but the most anterior fibers of the external oblique aponeurosis, if you imagine it's kind of draped down and its bottom edge is rolled inwards to form the ligament, as you get towards the midline, the superficial ring essentially is just formed by opening in the crura, right? Essentially above the pubic tubercle. Do I go through the walls of the canal? Or? Okay, so with respect to the walls of the inguinal canal, does anyone know what they are, or want to maybe just call them out while I'm trying to find a photo of them? So the way I think about the inguinal canal and the walls that essentially make it up are, I kind of split it up essentially into a medial, middle, and a lateral third. So the reason for that is because if you're getting into, I guess, the specific anatomy of it, it's actually quite different in terms of its medial, middle, and medial, lateral third, yeah, those three parts. So most laterally, the anterior wall of the canal will be the external oblique aponeurosis. This isn't really a great photo, but okay, so if you see here, right, so here we have the transversalis fascia, this one here, right, so as your testes essentially goes through, it's going to go through the transversalis fascia. Here you have the transversus abdominis muscle, right? So its fibers will be running horizontally. Here, this one here would be the internal oblique, and this one out here, this one here, if you kind of follow it all the way back up here, is external oblique. Okay? Now, with respect to the transversalis fascia, it does not actually contribute to the canal or its walls itself. Okay, now the reasons, so even though it looks like it's going through, the reason why it doesn't actually contribute is because when it comes to the inguinal ligament, right, and we're talking about where these different muscles, the transversus, internal and external oblique, attach, the transversus abdominis, it attaches to the lateral third of the inguinal ligament. Okay, the lateral third of the inguinal ligament. Now, if you go back to what we were talking about earlier, where the inguinal ligament commences, right, it's in the middle. So if you have a muscle that's attached to the lateral third, then you know it's out of the way of the actual canal. Does that make sense? So I think that's something which I always kind of struggled to understand in the beginning until I just kind of learned where the muscle attaches to. That's why it's out of the way. Okay, and then if you're getting into like genitourinary, I guess, anatomy with respect to what contributes to the spermatic cord, that's why the transversus abdominis does not. Yeah, because I won't go into that part, but so transversus abdominis, it doesn't contribute to so it essentially just forms the roof. Yeah, it's passing over. It's attached to the lateral third, right, and it essentially goes over the inguinal canal. So what does it contribute to? It's the roof. Okay. Then you have your internal oblique. So laterally, internal oblique with the external oblique aponeurosis is forming the anterior wall. Okay. Then as you can kind of see here, the internal oblique, its muscle fibers will actually arch over, right, the inguinal canal. So the internal oblique is probably the most hardest to, I guess, visualize because laterally it's forming the anterior wall, right? In that middle third, what we see is it actually arches over, so it's forming the roof in the middle, right? And then as you get to the medial third of the inguinal canal, right, the internal oblique goes behind, right? So it kind of does this funny approach where it starts in front, laterally, right? It then goes over, right? So if we're thinking that this here is the left side, right? So it starts in the front with the external oblique aponeurosis, right? Then its muscle fibers will arch over, right? And then it will land behind for the medial aspect, yeah? So the medial third, right? The internal oblique kind of joins with the transversus abdominis, right? To form that thick, strong conjoint tendon. Yeah? Is that okay, or is that a little bit too much? Yeah. Anyway, so that's why you have that kind of shutter effect, yeah? So that arching fiber which forms the roof, right, of the inguinal canal, right, it's composed of fibers from the internal oblique. It's supplied by your ilioinguinal nerve, right, such that when it's cut, yeah, then you're going to essentially predispose someone to a hernia, right, because when that nerve is stimulated, it kind of has a trapdoor effect where it closes the inguinal canal, say when you cough or when you, I guess, any process which increases intra-abdominal pressure. So that's what generally prevents hernias or bowel just going through the canal. Yes, that natural mechanism. So if someone, I guess, in old days, whatever, just had an open appendectomy, you cut that nerve, right, then they essentially lose that ability to close that inguinal canal. Yeah, it's all involuntary anyway, but it doesn't happen, and then they might be predisposed to inguinal hernias. Does that make sense? Yeah. All right, so I'll move probably a little bit quicker, but going back to, I guess, the inguinal ligament itself, right? So the orientation of, I guess, what's passing behind it. So if you can kind of think about it in two parts, right? So laterally, you have your iliacus muscle, which is here, right? It passes down laterally behind the inguinal ligament together with the psoas major muscle, right? So in terms of, maybe we can look at it more closely on the model soon, but the iliacus is just attached to that internal surface of the ilium, right? Psoas major is coming down, so it's attached to the the transverse processes of your lumbar vertebra as well as your anterolateral aspect of your vertebral body, right? Of L1 to L5, right? So it will descend down, join with the iliacus muscle, right? And then you essentially have iliopsoas, which will attach, does anyone know to what part of the femur? So it's your lesser trochanter, right? So it's at the back, yeah? So that's why it obviously has that important function in flexion, right, of your trunk, right, or flexion of your hip. So I guess the more important structures are those which are medially. So that important arrangement, right, going from lateral to medial, you have your femoral nerve, right, then your artery. So remember, you can palpate your artery below the ligament by going to your mid-inguinal point, so halfway from your ASIS to your pubic symphysis, right? And then medial to the artery is your femoral vein, right? And then medial to your femoral vein, right, you have your femoral canal. So in terms of what the femoral canal is, yeah, so it itself is dead space, right? Now the reason why you essentially have empty or like potential space there is because when you think about it, it's next to your femoral vein, which is very collapsible. If you're lying down, if you lift your legs up, right, you need to have some sort of expansile or volume which the femoral vein can expand into. Yeah, so for the most part, the femoral canal itself is empty, it just contains lymph nodes, right? And it allows increased venous return, yeah, during periods of, well, say if you elevate your legs, for example. In terms of what else is running through there, so you have your lymph nodes, which are draining the lower limb, yeah? Okay, so the femoral sheath, so how does that differ to the femoral canal? So femoral canal, it's that dead space that's containing lymph nodes, right, or lymphatics. The femoral sheath is just an aspect of the fascia which extends down. It encases the femoral artery, vein, and the femoral canal. Okay, so the nerve isn't actually within the femoral sheath itself. Yeah? So the femoral canal, so that's where if you have a defect in your wall, so it's, I think, a lot less common than inguinal hernias, but if you have anything that kind of protrudes through down into there, that's your femoral hernia. Okay? Is that okay? Am I going a little bit too quick? Or that's okay. All right. Any questions on that? The inguinal canal, the inguinal ligament. Okay, so we'll then, I guess, kind of just naturally go further down and then talk about the femoral triangle. Does anyone know the oh, it's not along here, but anyway, but okay, so no, it's not. So does anyone know the boundaries of the femoral triangle? Yep. And yeah, exactly. Yeah. So it's a triangle that's essentially having its base point, its apex pointing down. Yeah. So the base of it is the inguinal ligament, right? Then it's the medial border of Sartorius. So this is Sartorius here. So it kind of wraps around. Yeah. It goes from ASIS, yeah, down to the medial aspect of the tibia. Yeah. We can have a look at specifically where in a moment on the model, right? Then you have the Adductor Longus, right? Now, with respect to the contents of it, it's essentially those things we've already talked about, yeah? So your femoral artery vein, yeah? Nerve as well will pass down through there. Any questions on that? No? Okay, so maybe we can, so also, what we're kind of seeing here as well, since it's already open, that there, what's this vein? Yeah, so that's your great saphenous, right? And if we're kind of speaking more, I guess more detail of the femoral triangle. So apart from its borders, right, so its floor, right, or what these structures are essentially lying on, is you have your iliopsoas, right, which is, we can see it here, so it's essentially going to be forming that floor of it, right, and also pectineus, which would be this muscle here, right. Now, if you kind of think, well, if that's the floor or the base of it, then what's covering this whole thing superficially? There's a fascia, it's just called like Cribriform Fascia, right, and it's through that, which the great saphenous vein will essentially perforate or go through to then drain into your femoral vein. Yeah, the saphenofemoral junction. Okay. Maybe it might be then easier, so we don't waste time just looking for all these photos. We can have a look at the model.
Yeah, go for it. You guys want to come up and you can check around. Move some chairs up as well.
Yeah, bring some chairs. Oh, great. Thank you. Okay. So, upper and lower limb is probably what I always found to be the driest kind of parts of anatomy. There's a lot of like rote learning, and I remember when I was first learning it, it always seemed just quite difficult to conceptualize. Everything seemed to be memorizing. So, I guess since then, an easier way if you wanted to think about it, or just learning in big concepts, is if you think, you've already had the talk on, I guess, the upper limbs, but if you think about your upper limbs, right, where different structures and compartments are located, the lower limbs, right, are essentially the reverse. Yeah, so if you think about your upper limbs, right, your arm, right, and then forearm, so your arm, your flexors are in your anterior compartment, extensors are in your posterior compartment. In your thigh, right, you have the same thing. You have two compartments, essentially, or kind of three, right? But you have your anterior and your lateral, your posterior, okay? And it's the reverse, right? So in your upper limb where your flexors are in the anterior compartment, right? Lower limb, right? In terms of what's flexing your knees, right? It's going to be in the posterior compartment, yeah? Your hamstring muscles are responsible for flexing the knee, yeah? Arms, anterior compartment flexes the elbow. Does that make sense?
Yeah.
Posterior compartment in the arm extends the elbow, anterior compartment in the leg will extend the knee. Yeah?
Is that embryology something?
Yeah, it is some sort of, yeah. I never kind of went into all the details of it, but embryologically it's essentially the opposite. Yeah? So if you kind of think even down in your feet, yeah, so exactly, and even down in your feet, right, you have your flexors, right, or think about your forearms versus your legs, okay? Here you have your flexor compartment, right? Your flexors in your leg is posterior. Yeah, extensors are on the back, right? In the legs, extensors are the anterior compartment. Does that make sense? Yeah, so I guess when you get to like all the muscles of the hands, right, versus all the muscles of like at the ankle that are kind of in control of the toes, that's where everything gets really confusing because you have all these different layers. You can think of it in the same way, right? In your hands, you have abductors, right, of your thumb. So you have abductor pollicis, you have abductor digiti minimi, right, for like your fingers, right? You have the same thing in your feet, right, except opposite, right? So in your hand where it's on the anterior, right, aspect, on your feet it's on the plantar aspect. Yeah, so we'll get to that eventually. But so just starting, so that was just essentially like big picture kind of ideas. So with respect to the thigh, right, that's essentially this whole thing. You have your anterior compartment, right? Essentially your quads, your medial compartment, your adductors, right? And then if you want to just think about it broadly, you have hamstrings out the back, okay? So what we already briefly mentioned, all right, I'll try not to drop this, right? So the femoral triangle, right? So here we can see Sartorius, right? So Sartorius, it crosses essentially two joints, right? Your hip joint and your knee joint. So it has dual action, right? If any muscle crosses a joint, it's going to have an action on that joint, however small it might be, right? So as we can see, this Sartorius is it's a minor flexor of your hip, right? And also, I think it extends. No, sorry, it flexes the knee as well, right? Because it crosses posteriorly, right? So this is Sartorius here. So it kind of wraps around. Actually, before we remove it, does anyone know what this sort of... Yeah, pes anserinus. And do we know what kind of contributes to it? So pes anserinus, you have three tendinous. The what, sorry?
So Sartorius,
yeah.
Graves, Gracilis,
yeah.
and semitendinosus too.
Yeah. Oh, great. Yeah. Okay. So pes anserinus is essentially, it means like goose's foot. Apparently this is meant to look like it. So it's where you have three tendons that come down and insert onto the medial aspect of your tibia. Yeah. And that orientation of where Sartorius is most anterior, gracilis, which is this strap, this thin strap-like adductor, right, will insert behind it, right? And then behind those two and lower down slightly, right, you're going to have semitendinosus. Yeah? Which, I don't know how well you can make it out, but so you have Sartorius, gracilis, semitendinosus, right? So it's just an easy way if you had to learn the attachments of these muscles, just to kind of, okay, remember you've got three covered already. Okay? So that's the medial aspect of the tibia. Right. I'll try to remove this without... Alright, so with respect to then the quadriceps, right, so as the name implies, there's four of them. One only, right, will cross the hip joint. Do we know what that one is?
Rectus.
Yeah, rectus femoris. Yeah, so rectus femoris is, while Sartorius is attached to the ASIS, right, rectus femoris is attached to the anterior inferior, right, iliac spine. So ASIS is here, right, and then it's kind of here, sorry. All right, so where my middle finger is, right, that's your AIIS, okay? I'm going to try that again. Okay, so the rest of them. All right, so if we remove rectus femoris, okay, then you just have the remaining three, which we can't remove, right? But you have vastus medialis, right? Vastus intermedius, right, which is right on the bone. Yeah, and then you have vastus lateralis. Vastus lateralis and vastus medialis, they're actually both attached to the posterior aspect of the femur itself, right? So if we're looking at the bone alone, here, that ridge, right, is linea aspera, and as you can probably see, so we're looking at the posterior surface. As you go down, right, and up, linea aspera kind of divides here into a lateral supracondylar line, medial supracondylar line, okay? If we kind of follow that down, it's not too prominent on this model, right, but as you follow down the medial supracondylar line, right, you have a little tubercle there, that's your adductor tubercle. That's where the hamstring part of the adductor magnus attaches. Yeah? So adductor magnus doesn't only adduct, right? But it's also considered to be, or it's to have a hamstring portion, right? So helping the hamstring muscles, which we'll come to shortly, also just flex the knee. Okay, kind of lost my train of thought with that. Yeah, so with the linea aspera, vastus medialis, vastus lateralis, they're actually attached back here, right, to either side of it. Lateralis to the lateral lip, yeah, medialis to that medial aspect, right? Then pretty much on that, or in between those, is where you're going to have your adductor muscles being attached, right? So the insertion of the adductor brevis, right, below which would then be adductor longus, right? And adductor magnus is kind of slightly lateral to both those, right, and goes all the way down, yeah, with a small portion also being attached to the adductor tubercle, that hamstring portion of adductor magnus. Yeah, sorry, there's, I don't know how well we'll be able to see it on this, that's why I just figured maybe we'll talk about it. I know it's really hard to conceptualize, yeah? But is that alright if I just kind of throw them out? I guess if you've read it before, hopefully it's just reinforcing. If not, hopefully it'll be a little bit easier if you come back to it. Okay, so that's pretty much the anterior compartment, right? Your quadriceps, done, yeah? So remember, you also have your Sartorius, which we already removed, but your quadriceps, so remember you have Rectus Femoris, right, which crosses your hip joint. The other three parts of quadriceps does not, right? So only Rectus Femoris, in terms of the quadriceps, is going to be responsible for any sort of hip flexion, right? But remember, you have a lot of other muscles that will do this. You have iliopsoas, which is a strong one, Sartorius to some extent as well, okay? So in terms of what we can probably keep removing, and we'll keep it like this. So before we move on to, I guess, a different compartment, another thing that we can see, so we've already talked about the femoral triangle, right? So remember we said it's what it's formed by. So the base is the inguinal ligament, right? Then you're going to have Sartorius kind of coming down like that, right? And Adductor Longus, which would be, I assume, 13 here. Yeah, right? So in that space, you've got what we've already talked about, your femoral vessels and nerve, okay? Now, if we kind of keep following that down and the path of the nerve and artery, okay, we're going to go into our adductor canal. Okay, so the adductor canal, do we know the borders of that? You can kind of look at it and see. So we've removed Sartorius, right, which is kind of covering it.
That's the root.
Yeah, so that's out then. So what we're really looking at is this muscle and this muscle.
Vastus Medialis.
Yeah, exactly, right? So vastus medialis, right, is kind of forming that lateral wall, right, of it. So we say it kind of has a roof, a lateral wall, and a posterior wall. Yeah, and what's this one here?
Adductor longus.
Yeah, adductor longus, okay? Then, and lower down, you got adductor magnus as well. Okay, now it's through adductor magnus which these structures will kind of go to then come out into the posterior aspect here, right, the popliteal fossa. Okay, so same thing, yeah, you've got your artery nerve, artery vein, and then I guess if we go, and then so it's going to open out into the back, right, through the adductor hiatus into the popliteal fossa, right? Popliteal fossa, we can see it quite easily, right, in terms of what its boundaries are going to be formed by. So it's this diamond-shaped space, I guess, formed by, well, we haven't talked through the hamstrings, right, but what's the, okay, sorry, trying to find a good way to hold it. Can everyone see that?
You can pop it in a stand if you want, come around the front.
Yeah, good idea. I'll probably keep taking it on and off anyway. Alright, but if you all can see that, alright, so what's this? So we're talking now about the posterior aspect, hey?
Biceps femoris.
Exactly, yes, so biceps femoris, Yeah, so biceps, because it has two heads, right? One with the semitendinosus, right? They actually have the same. So all your hamstrings, right? Semitendinosus, semimembranosus, biceps femoris, long head, right, are attached to the ischial tuberosity, right? So if we're holding it here, so ischial tuberosity is this part. Yeah, it's very rough, right? So whenever you're learning bony anatomy, any kind of bony landmark which is very rough is a tuberosity, right? Why is it rough? Because it gives attachment, yeah, to tendons and then muscles. Okay, so this one's really big. It's the same one which you kind of sit on. So if you feel it on yourself, it's that big bony kind of aspect, yeah, or part of the bone. So from here, you're going to have your hamstrings, yes. So biceps femoris, the long head, right, has the same attachment as semitendinosus. Yeah, and then superlateral to that, you're going to have semimembranosus, still on the ischial tuberosity. Okay, part of the adductor magnus as well has attachment to here. Yeah, but most of it is from your inferior pubic ramus. Yeah, with the other adductors. Okay, so if I won't try to remove this because I don't think I can.
I think you have to take the glute off first.
Okay, good. All right, so by the way, so we just talked about the origins pretty much of the hamstrings, right? Except for one part of it. So we said, hey, oh, good. All right, so we said long head, right, is coming off ischial tuberosity, right? What about the short head of biceps? Yeah, right, so it's coming off the back part of the femur. Yeah, so more specifically just below the gluteal tuberosity, which is, again, tuberosity, right, roughened part of a bone, right, where a muscle will attach via its tendon. Gluteal tuberosity, yeah, gluteus maximus, we'll go there. Okay, so when you're, I guess if some texts, like, I guess all those, like, detailed anatomy ones, they, for some part, don't actually consider short head of biceps femoris to actually be part of the hamstrings. Yeah, one, it doesn't extend the hip, yeah, because it doesn't cross the hip joint. Yeah, because it's attached to the femur itself. It doesn't cross that joint. Two, with respect to its nervous supply, right? So it itself is supplied by the common peroneal nerve, okay? Whereas the rest of it is sciatic, okay? So, speaking of, right, so this big nerve here, right, is your sciatic nerve. I think it's the longest nerve in the body. Yeah, so it's going from L4 to S3, okay? The sciatic nerve in terms of its origins, right? So the sciatic nerve is going to descend, right, between your hamstring muscles, right? It will essentially run down. In the popliteal fossa, generally, right, is where the sciatic nerve will split into its two terminal branches, which are... Yeah, so tibial common fibula or common peroneal nerve, yeah? So fibula, peroneal, same thing, yeah? And we can see that here. Okay, now if I was to ask you, so can everyone see how it's split, yeah, into two nerves? If you had to then say, okay, which is tibial, which is common peroneal?
Common peroneal is the lateral.
Exactly. Yeah, so common peroneal, right, it's lateral. Then, do we know what it does? Exactly, yeah. So it wraps around the neck, yeah, or of the fibula. So you can get injured, and I remember when I was taught it, like, it called like dashboard injury, right? Like, I remember my teacher would always say, like, you know, the injuries he saw would always essentially be females who were sitting like cross-legged in a car or something, and then impact, and then they just kind of bang that part of the, like, essentially where the head and neck of the fibula is, right, against a dashboard, and then they just have some sort of weird sensation going down. So that's how I remember. So with respect then to what the common peroneal nerve does, do we know? So after it wraps around, does it continue down as common peroneal, or does it split? Does it? Huh? Exactly, yeah. So it's going to split into a superficial and deep peroneal nerve, okay? So the leg, so I think we covered all the compartments, yes? So in the thigh, so you had your anterior, right, which is essentially your quadriceps, sartorius, yeah, pectineus as well is kind of there, right? Pectineus flexes the hip as well as assists in adduction. Pectineus makes the floor of the femoral triangle with iliopsoas. Yeah, remember the medial compartment is your adductors. So you have adductor brevis, adductor longus, adductor magnus, gracilis. Right, so you can just generalize into thinking anterior compartment supplied by femoral nerve, right? Posterior compartment sciatic, yeah. Medial is obturator nerve, Okay, if you had to, sorry I'm kind of jumping around, I just didn't want to go down here and then I just wanted to finish off up here. Okay, so the other thing is, easy way to tell the difference in terms of femoral and obturator nerve, right, is their orientation to solus major. Okay, so if we had, I guess, you can still see it on this, but a model of the trunk, right, where you see solus major, right, if you're learning the lumbosacral plexus, so that's essentially like L5 down to like S3, yeah. Solus major is a really good landmark to help identify where you're at. Yeah, so just really quickly, so we can knock out the nerves. So L1, you're going to have two nerves essentially having its origins from there. Iliohypogastric, ilioinguinal. Yeah, we briefly talked about ilioinguinal earlier and its role in the inguinal canal. Yeah. Okay, L1, L2, right? You're going to have genitofemoral. Yeah. So genitofemoral, remember, so it's really easy to identify on models and cadavers, on pictures, anything, because genitofemoral will come through, right, or it pierces the solus major muscle. Okay? Genitofemoral has two parts, a genital, right, branch, and then femoral, right? Okay, so then you're going to have, I guess, the main ones after that, right? L2, L3, right? You're going to have the posterior lateral cutaneous. Yeah, it's a cutaneous nerve that will go essentially supply the thigh, right? Probably the more important ones then is your femoral and your obturator. So in terms of how to identify those two, so it's their relation to your solus major muscle. So your obturator nerve, can you guys see that okay? You have a nerve coming through there, right? Medial to solus major, right? So that there is obturator, right? Nerve which is coming from the same ventral roots, right? Which is arising lateral to solus major muscle is going to be a femoral. Okay, remember, we've already essentially talked about where femoral is going to go down, right? Down through or behind your inguinal ligament, yeah? Lateral to your femoral artery, yeah? Supply mainly the anterior aspect or your anterior compartment, okay? And then it'll just kind of terminate down as cutaneous branches in the leg. Specifically, actually, I don't know if we mentioned this, but with respect to the contents of the adductor canal, so apart from your artery vein, you have two branches of your femoral nerve as well. Okay, so it doesn't just kind of keep going as a strong nerve like your sciatic does. Do we know what branches those are?
Pretty much the Vastus Medialis.
Yeah, good. Yeah, and?
I'm going to say that one's the Vastus Medialis.
No, so close. No. So you have so femoral nerve, right, in the adductor canal, right, is two branches of femoral nerve. So you're right. So a branch to the Vastus Medialis and then saphenous nerve. Okay. Yep. Okay. So sorry for jumping back up here. I don't think there's anything more right here. Now we can get down to the leg. Yeah. Any questions so far on this stuff? Okay, so I think where we were last, we were talking about the sciatic.
Actually, sorry, if you just point out the different adductor muscles, just so
Okay.
I feel like
Yep. Okay, so I don't think I pulled any off. So this was our rectus femoris, Sartorius. So looking here, okay, so this long, thin strap muscle, right, is going to be? Exactly, gracilis, yeah? And whilst everything kind of looks the same and confusing, remember, gracilis is kind of separate from the other adductors in that it's distal attachment, which we talked about with respect to that pes anserinus orientation. Okay, so it's inserting into that medial, or just inferior to the medial tibial plateau, which we don't, I think, have a tibia alone, but that's okay. So it's just this part here, yeah, we can see it quite nicely. So that thin strap-like muscle, right? Anterior to it is sartorius, right? And posterior to it is going to be semitendinosus. With respect to the adductors, though, here, right, would be adductor longus, yeah? I guess above adductor longus and behind pectineus, right, which is this one, right, you would have adductor brevis, okay? And kind of behind those two, adductor brevis and longus, right, going down, right, would be adductor magnus, okay? Adductor magnus kind of has a almost like a break in it through which the structures, your femoral artery vein, right, is going to go through in order to get from the anterior compartment to the posterior aspect. Yeah, is that okay?
Yeah.
Okay, so with respect to, I guess as we make our way down, okay, so on the femur, so this kind of smooth, soft, or not soft, this smooth aspect here, right, is your popliteal. So that there is your popliteal fossa, or popliteal surface, yeah? It's forming the floor of your popliteal fossa. Have we talked about the contents through there? Right, so remember, as your femoral artery and vein, right, will come through into this popliteal fossa. Same structure, it just changes its name now to popliteal. Okay, so popliteal artery, popliteal vein. Okay. With respect to the popliteal vein, I don't know how much there is to say about it, but with respect to your short saphenous, right, vein, it's going to essentially jump into or drain into that, right, in the fossa. Yeah, or a little bit lower down. Now, I think something that's worth mentioning is the orientation, right, of your nerve. All right, so now we're talking essentially about, so the sciatic nerve if it hasn't split, or tibial nerve if it has, as in this model's case. Yeah, but with respect, the orientation of the nerve, artery, and vein. Okay, so remember up there, right, so going from lateral to medial, right, you had nerve, artery, vein. Okay, do we know without, no, it's kind of, actually, no, it doesn't really give it away. But what's the orientation then of the nerve, artery, and vein here in terms of superficial to deep?
Artery's deep. I know that deep
Correct.
and medial.
Yep. Yeah, so you're right. Artery is the most deep. Yeah, so tibial artery is the most deep. So when you're kind of palpating it, even on like skinny people, it's almost, I don't know, I've always struggled to palpate it on like big people, skinny people as well as submission. You really got to, what you're trying to do is compress it against the bone pretty much, right? So you can feel the it palpating off that, right? So artery is most deep, right? Then popliteal vein is sitting on top of it, right, or more superficial to it, and then superficial to that is going to be the nerve, right? So your sciatic nerve. If it's split, right, then it will be tibial, because tibial will go straight down, right, into your posterior compartment. Remember, your common fibula, right, or common peroneal nerve is going to go out laterally, as we can see here, right, to wrap around the neck of the fibula. Okay. So it took us. And last thing that I think we may have already covered is the popliteal fossa itself, right? So its boundaries, right? So laterally, you're going to have, so laterally out this way, you're going to have what tendon? So remember, you got your hamstrings here, yeah? So exactly, so going down, right? So the superior, so it's a diamond pretty much, right? And the two superior borders, laterally is going to be your tendon of biceps femoris. Medially, you're going to have semitendinosus, semimembranosus, right? And we can, I pulled them off, but okay, I'll just kind of hold it briefly there, yeah? So semitendinosus, semimembranosus here medially, biceps femoris here out laterally, right? Biceps femoris itself is going to insert into the head of the fibula, yeah? With the nerve going down, wrapping around its neck, right? The inferior boundaries is just going to be your lateral and medial head of gastrocnemius. Okay, so gastrocnemius, right, is essentially considered part of that triceps surae muscles, right? So what's that? Well, it's the triceps surae. So three muscles make up the superficial compartment, right? Superficial posterior compartment of the leg. Okay, so in the leg you essentially have 4 compartments. Yeah, you've got an anterior, right? But in reality, I guess it's more anterior lateral. Right, because you got your tibia here. Right? You don't have any. You can feel it all on yourself. You just got straight up bone, right, on that anterior medial aspect. Right, so anterolaterally, right, or anterior compartment, right. Then you're going to have out the back, or you're going to have a lateral compartment, right, which has 2 muscles, which are Peroneus Longus and Brevis. Okay, Peroneus Longus will go down to the foot. So it's essentially Peroneus Longus, Brevis. Their tendons are passing deep, right, to the what are these kind of structures called that kind of straps everything down? Retinaculum. Yeah, retinaculum, yeah. So you have extensor retinaculum, right? Specifically there's a superior and inferior one, but we won't get into all that, right? So you have an extensor retinaculum, right? A peroneal or peroneal retinaculum, right? Behind which your Peroneus Longus, Brevis are going to go. And then you have a flexor retinaculum, which is kind of out back here. But just to, because this is I think where it gets quite confusing here downwards muscle-wise, but lateral compartment, muscles, Peroneus Longus, Peroneus Brevis. Peroneus Brevis, right, will go down and it will insert essentially into the base of the fifth metatarsal. Okay, Peroneus, okay, so see this muscle here, right? So it's kind of, if we had to kind of put a number to it, it's this one here, I think 17, right? So it's going down behind the lateral malleolus, right, deep to the peroneal retinaculum or fibular retinaculum, whatever, and then it's going to insert into the base of the fifth metatarsal. Okay, Peroneus Longus is something quite odd, right? So it's passing down deep posterior to the Peroneus brevis tendon, and it's going to go down on the underside of the foot. Yeah, and we'll go specifically into that in more detail when we go through the 4 layers of the foot, right? But whilst the brevis is attached to the base of the fifth metatarsal, do we know where the Peroneus longus tendon is inserted into?
First metatarsal.
Yeah, so the base, right, of the first metatarsal, and it's very deep. Yeah, I think it's we'll come to it actually going through this. It'll be so with respect then to the posterior compartment of the leg. So you have a superficial and a deep compartment. Superficial compartment, right, is essentially made up of the triceps surae. Okay, so what makes that up? So you have your gastrocnemius. Okay, so medial and lateral heads are pretty much forming the bottom parts or bottom boundaries of the popliteal fossa. Okay, I think this comes off. All right. So, yeah, so gastrocnemius, if we kind of took that out, we have a thin kind or a small muscle belly, right? And then a long tendon here. What's that? Plantaris. Yeah, so plantaris, and then this big one is soleus. Yeah, so soleus doesn't actually cross the knee joint. Yeah, so it's not actually involved in any sort of flexion or movement at the knee at all. Soleus. Yeah, plantaris, gastrocnemius, they do. Right, and they essentially all insert via a common tendon, right, into that posterior aspect of the calcaneus. Yeah, so just in lay term, that Achilles tendon, okay, or calcaneal tendon, I think it's called as well. Okay, so we'll leave that. Okay, so maybe since we can see it all on show here, right, the vessels, right, and nerves. So with respect to the popliteal. So the popliteal vein, right? So the vein will just follow the posterior tibial artery. Okay, so we'll just leave the vein and talk about the arteries. So remember, we went from femoral artery, right? We changed name to popliteal artery once we came through the adductor hiatus, right, into the popliteal fossa. Okay, so popliteal artery, right? Remember, it's the deepest of those structures in the fossa. Now, the first thing it will do is it'll send off an artery that kind of goes. That dives like anterior through there, right, over the interosseous membrane, right, interosseous membrane, which is kind of binding the tibia and fibula. Okay, so the artery that goes anterior, right, and then down, right, is going to be anterior tibial. Okay, anterior tibial is going to be essentially the artery of the anterior compartment of the leg. So we can see it here. Can everyone see that if I rotate it? Yeah. So anterior tibial artery. Remember, it's come off the popliteal artery, right? After the popliteal artery gives it off, then it briefly changes its name to a tibia peroneal trunk, right? Before it essentially gives off the common peroneal, right, or peroneal artery, and then it will continue down in the posterior deep compartment as posterior tibial artery. Okay, so we'll just briefly follow the anterior tibial artery, right? So it's going to come down, right, and the reason why I'll just briefly go over it is because in the dorsum of the foot, it's that artery, right? So remember, it's traveling lateral to extensor hallucis longus tendon, right? And that's what you can feel as the Dorsalis Pedis, yeah? Arterial pulse, okay? With respect to the posterior tibial artery, so it's accompanied by the tibial nerve, yeah? With respect to, okay, hang on, how do I do this? Okay, that doesn't come off. All right, so either way, all right, so this is, I think, well, here we go, maybe on this. All right, so I just want to maybe show this orientation, right? Because we have a lot, rather, on this side. we have a lot of kind of tendons and structures going through. I think I can take this off. All right, so triceps surae, yeah, so we're going to take this off. So this, the actual muscle bulk we can see here would be soleus, yeah, that part, this tendinous part would more likely be from higher up and more superficial, the gastrocnemius, yeah, and kind of deep and medial, right, within that would be plantaris, okay. So now we see all these muscles, this isn't too bad. All right, so we'll just briefly go over, right, so what's passing under the medial malleolus. Okay, so we've got three tendons, artery, nerve. Yeah, but so I always kind of remembered it or got taught it in terms of just that saying like Tom, Dick, and Harry. Okay, so T, right? Okay, so tibialis anterior, right, will go kind of first. Jokes. Tibialis posterior. Sorry, so we're talking about the posterior compartment, deep posterior compartment, right, and how it gets to the foot. So passing behind the medial malleolus, right, your first is going to be tibialis posterior, right, so that's the T in Tom, Dick, and Harry. So then the D is going to be, remember we're talking about posterior compartment, so you have flexor digitorum longus, right, then you got your artery, nerve, right, and this is actually kind of maintained that anatomical location as well, right, so artery, nerve, right, so that's where your, so T, remember, Tom, Dick is for flexor digitorum longus, right? Artery, nerve, right? So that's the and, right? So artery, nerve, posterior tibial artery. That's why you can feel it, right? Behind the medial malleolus. That's where you're going to go to palpate it. Tibial nerve, right? Which as it passes down behind, right, and emerges on that plantar aspect of the foot, tibial nerve and artery, right, will both change their names to medial and lateral plantar, yeah, artery or nerve, okay, right, then this last one, right, will be which muscle? Hey, sorry? Flexor hallucis longus, exactly, right, so when you're kind of looking at it, it almost seems quite counterintuitive if you were to think about where it sort of attaches, right, so this might work. So here, right, what we're seeing, this is going to be really quite difficult to see, but this cross section, right, is really the deep compartment, right, deep posterior compartment, okay, what my finger's over, right, so the three muscles, right, that we care about there, one, right, is essentially lying right on the interosseous membrane, okay, that there is tibialis posterior, okay. Then you have essentially two other muscles, right, so here and here. You would think, I guess, just by looking at your foot and where your big toe is, that the flexor hallucis longus would be on that medial side, right? So it just goes straight down and to it, right? But it always, so it's on the opposite, yeah, which just always seemed counterintuitive to me. So again, here's your big toe, right, which is obviously medial. If you're looking at a cross section, okay, so remember here, they've made it quite massive, right, would be flexor hallucis longus, right, here, flexor digitorum longus, yeah, so flexor digitorum longus, flexor hallucis longus, okay, so because obviously it has that reverse orientation, right, where the flexor hallucis longus, instead of being on this side, right, is actually on this side of, remember we're talking about the back, right, it's on this side of flexor digitorum longus, right, it crosses deep, right, to the tendon, and we'll see that in the layers of the foot, right, it will cross deep to the tendon of flexor digitorum longus, right, in order to get from essentially coming down on this side, right, flexor digitorum longus is on this side, they cross, yeah, so flexor digitorum longus is on the other side, right. Now, how much detail, I guess the 4 layers of the foot we need to go into, that'll probably be boring and might just get really confusing. We can do it, we can try to do it, see how we go, but maybe just more broad concepts before that. So just briefly, with respect to, I guess, a little bit of clinical anatomy, and we briefly mentioned the common peroneal nerve, okay? So we had 4 compartments, right? So your common peroneal nerve, it's going to split into a superficial and deep. Superficial, right, motor will supply your Peroneus longus, Peroneus brevis, yeah, so that lateral compartment. Superficial will then essentially become a cutaneous nerve that will supply the skin pretty much over all of the dorsum of the foot, right, except for a small aspect, right, which is supplied by the deep peroneal nerve in terms of skin. Do we know where that is, or what that is? exactly. Yeah, it's like that. Yeah, where like, you know, your thong kind of thing. If you're wearing thongs, like where that skin is kind of touching, right? So that. Yeah, that one. So pretty much the webbing between your first and second toe is going to be cutaneous. Is going to be supplied by the the deep peroneal nerve. Okay. Any questions on that? I kind of went over that pretty oddly, I think. Yeah. Okay. So I guess in terms of all that clinical anatomy. With respect to dermatomes, right? So if you're going from, I guess, more limbs, so kind of in this region here, you're going to have L1. Going down in, I guess, across the thigh, you're going to have L2, and then you move down across the knee, L3, right? Medial aspect, right, of your leg will be L4. Lateral aspect of the leg, right, and dorsum of the foot will be L5, right? And then you kind of have those stripes for your sacral dermatomes along the back. Yeah, and then it kind of forms the rings around the, around the anus. Okay, any questions? So I know muscular anatomy I always used to hate and found the most confusing.
So what's the mnemonic
Huh?
for the other side, the other retinaculum?
Which one, sorry?
So
The lateral and the medial.
So the lateral, well, here you're just going to have, what two muscles? Your lateral compartment, yeah?
so
Tibialis longus.
Yeah,
brevis.
and Tibialis Longus and brevis. And remember, brevis is just going to go behind, right, and go straight there. So it's passing deep to the retinaculum, right, and it's just going to insert into the base of the fifth metatarsal.
It's just those two.
Yeah,
things.
yeah.
That's it.
Yeah,
Okay.
even like you may have seen. So there's Peroneus Ptosis as well, right? But that isn't passing behind this this lateral retinaculum or this peroneal retinaculum. Yeah, so Peroneus Ptosis is actually here, right? So it's part of that anterior compartment. It'll pass deep to the extensor retinaculum, right? And we'll insert with the brevis. I don't think we can see it here, right? But it'll insert with the brevis to that base of fifth metatarsal. It's not super important, right? But it's just so you're aware.
and then
So
the extensor retinaculum.
Mm.
Timothy has a very nasty disease, parotyphoid.
Whoa, okay. Yeah.
So what's
The
this
PT
retinaculum?
is the
Extensor.
That's what she's talking about.
Yeah,
And this one?
yeah. Sorry?
And this one?
Timothy.
So,
This one where you talked about Tom, Dick and Harry.
yeah, so that's going behind that medial malleolus. So we essentially, well, it's kind of like more back here, right? You're going to have a flexor retinaculum. Because remember, this is your flexor compartment,
Okay.
right? And when I was talking about that Tom, Dick, and Harry, that was going essentially from anterior to posterior, right? So here, right, would be tibialis posterior,
Yeah.
right? So T, right? Flexor
Okay, so
digitorum
there's only
longus.
two retinaculums. There's this one.
Yep.
There's this one. There's not.
Well, yeah.
Sorry.
They did.
Okay.
Yeah.
I think
Well, there
texts
is, but
actually
it's not
do cause
important
it,
to
yeah.
remember a mnemonic for it.
No, yeah, because there's only those two.
Yeah. fair enough.
Yeah, so tibialis posterior, flexor digitorum longus, artery, nerve, right? So tibial, posterior tibial artery, tibial nerve, and then flexor hallucis longus.
Okay.
Yeah, and then if we kind of just kept going around to that lateral aspect, you're looking at Peroneus longus muscle here. Yeah, Peroneus brevis muscle belly here, right? The tendon of which is here, going to the fifth metatarsal, and this long tendon, right, is going down. We can see deep in the foot, right? So that's a tendon of Peroneus longus. Yeah, that's going to go out and across under the foot, right, to then join to the base of the first metatarsal.
Yeah.
Yeah, so Peroneus brevis will attach to the base of the fifth metatarsal. Peroneus longus goes down deep, right, in the foot, right? So it's one of the deepest kind of layers, right? That's going to go down and insert into the base of the first metatarsal. Ugh, okay. All right. So, do we want to do the layers of the foot?
Look at it.
Like, what, I don't even know what that is.
Yeah. All right. So again, right? This is probably quite similar. Again, if you had to try to think about it in some sort of way to make, I guess, it less of rote memorizing, right? Which I think some parts of anatomy, unfortunately, are. Right? It kind of fits in quite nicely with the upper limb, right? Which is a whole thing I was trying to begin with. Okay, so I guess with all anatomy in general, you can always think, well, if you've got a longus of something, you're going to have a brevis, right? If you've got something superior, you've probably got something inferior, yeah, in terms of its naming. Yeah, if you've got a superficial, like our common peroneal nerve will then divide into a superficial peroneal nerve, you know you're going to have a deep peroneal nerve. Yeah, so with all these muscles that we're talking about, right, the ankle movers pretty much, right, so in your deep, or in your anterior compartment or your deep posterior, right, a lot of them are longus, right, flexor or extensor, hallucis longus, flexor, extensor, digitorum, yeah, okay, so this is where you're going to kind of meet all the other ones, right? The brevis and whatnot. So remember, in your hand, right? That movement is called what? Like moving. Exactly, right? So what do you have moving your thumb out, abducting your thumb? Abductor.
That's
Yeah.
extension. That's abduction.
Yeah. So abduction, right? You're moving away, right, from its midline. Extension, you're going back. Yeah. No? Am I wrong? Oh, is it coming out then? Yeah.
Yeah, that's
All right, so either way, so same thing, right? Where you've got an abductor pollicus and then an abductor digiti minimi, right? Well, you essentially got that same thing here, right? So you've got, so in terms of the first layer, and I always confuse this myself, so, but it should be okay. So I just remember, so first layer, like AFA, so you're going to have abductor pollicus, right? And then you're going to have an abductor digiti minimi, right? Which are responsible for just kind of moving them out. Yeah, your first toe. Sorry, abductor hallucis, yeah, and abductor digiti minimi, right? And then the F in the middle, right? So that's going to be, so what compartment are you here in? So your flexors, right? We're flexing the toes on the plantar aspect. Okay, so flexor. Well, not superficialis, because what was it called up here? It was flexor digitorum longus.
Oh, yeah.
So flexor digitorum brevis. Yeah, and we can see that just by virtue of the fact of its 4 tendons, right? You know it's going to go out to these, yeah, toes. All right, so that's layer number 1. Between layers number 1 and 2, you're going to have your neurovascular layer, yeah? So do you remember what the, just broadly, the nerves and arteries we mentioned? Remember, it's... Well, yeah, so you're going to have a lateral and medial plantar. Yeah, artery, plantar, lateral medial plantar nerves as well. Yeah, so remember they're coming down from this one here, posterior tibial, right? And as we get, okay, so that remember travels between, that neurovascular plane is between layers 1, right, and layers 2. So I don't know how much we'd be able to kind of remove out. Okay, so layer 2, I just remember as 2 tendons, right, and then 2 muscles, right, or associated muscles that are attached to those tendons. All right, so let's see. No, I think this is actually layer 2 that we're moving out. Hopefully I'll be able to put this back together. All right, so does anyone know what 2 tendons we're talking about?
It's flexor digitorum longus.
Yep, good.
And flexor hallucis.
Exactly, yeah. So remember, right, so they're coming down from here, right? And specifically, remember we said that there's a weird orientation up here in that the flexor hallucis longus is actually on the lateral side, right? If you're lateral kind of, it's more lateral than flexor digitorum longus, right? And therefore the tendon has to cross, right? So in your second layer, again, I'll try to, so see, here is I think what they're trying to show, right? The tendons for flexor digitorum longus, right? Ignore those muscle bellies that we see. I'll say what they are in a sec. Okay, so the 2 tendons, right? So layer 2, 2 tendons, right, and 2 associated muscles. So here we see the tendon, right, of flexor hallucis longus, right? Now remember I said it crosses deep, right, to the tendons, right, of flexor digitorum longus, right? So again, this being more superficial, if I place it there, we can see that the tendon here, right, of flexor digitorum longus is deep and it's being crossed, or is crossing, right, these tendons here, right, which is going to be flexor digitorum longus. Yeah, sorry, I don't, it's a little bit confusing, but does everyone understand that? Yeah, or at least understand those 2 tendons in layer 2? Okay, now with respect to, I said, so layer 2 has 2 tendons, right? So we've identified those, flexor digitorum, flexor hallucis longus, flexor digitorum, yeah, longus. Now the 2 muscles, right, which are, so there are 2 muscles as well, they're attached to the tendons of flexor digitorum longus. Okay, so posteriorly, or I guess more proximally, right, it's called, what is it? All right, so more distally, you have lumbricals, right, so 4 lumbricals, right, more proximally, it's, has a weird name, something accessorius, Flexor accessorius or something like that. No? Okay, all right, so this is, yeah, the 4, like the 4 layers of the foot. Yeah, okay. Yeah, so it's like, it's almost like accessory flexors.
I just remember L for layer 2, and that's
Okay.
long tendons and lumbricals. That's
Okay, yeah, so that's good as well, yeah? It's easier, and you're probably not going to confuse it like I am, right? So I think you're right, in that the probably more important things to remember, right, and also functionally, right, is, well, the 2 tendons, right, so flexor hallucis longus, right, is crossing deep to the tendons of flexor digitorum longus, right? The more, I guess, distal aspect, right, of flexor digitorum longus, you're going to have these little muscles, right? Those are your lumbricals. Okay, you have accessory flexors as well, which are attached more proximally, but I don't think this is even really showing it. Okay, so then you're kind of moving on to layer 3. Okay, so I think this one here, by the way, that we've just taken off, would be from layer 1. What do you reckon it would be?
abductor.
Yeah, abductor hallucis, yeah. Remember on the foot, on the little toe side, yeah, lateral, you're going to have abductor digiti minimi. Yeah, so we've removed that. We've removed half of layer 2. I say half of layer 2 because we've removed the tendons, right, of flexor digitorum longus, right? We can still see the tendon of flexor hallucis longus, right? But through that, right, or behind that, we can see 3 muscles that make up the 3rd layer, okay? So the way I kind of remember is layer 1 is like AFA, right? Layer 3, all right, layer 3 is the reverse, so it's like instead of AFA, like FAF, okay? So remember we said we have a lot of muscles that we're talking about in there, longus, right? If you got longus, you're going to have brevis, right? So layer 3, you're going to have a flexor hallucis brevis, flexor digitorum brevis, right? So just looking at this here, I can see flexor hallucis brevis, right? It's having this longitudinal orientation, right? I can't really see, I guess confidently, the flexor digitorum brevis. Maybe I removed it, I don't know. Right, but what I can see as well is this like sort of oblique running muscle, right? There's 2 muscle heads, one's running oblique, one's running transverse, right? So I'll run my fingers over it, these ones. Right, now in your hand, you have something similar, right, that is there for the thumb, right? So what's that in the hand? Adductor pollicis, right? So here is, exactly. Okay, so remember I tried to kind of start out broad by saying upper limb, lower limb, there's a lot of like muscular stuff and it can be just rote learning, but always think in compartments, yeah? And this is probably where it becomes even more easier, I guess, if you wanted to, because it's either really confusing memorization of your hands, right, and the 4 aspects or 4 layers of your foot, right, but if you kind of think in that orientation, right, it becomes a little bit easier, right? So in your hand, where adductor pollicis has 2 muscle bellies, right, you have an oblique head, you have a transverse head. The same here with adductor pollicis. You have a transverse, right, head, you have an oblique head, okay? So remember, that's layer 3, so FAF. Right, so flexor hallucis brevis, flexor digitorum brevis, right, and also adductor pollicis. Makes sense? Okay, and this is so many layers. All right, and then that 4th layer, right, pretty much right before you hit bone, is just going to be your interossei. Okay, so again, in your hands you have palmar, dorsal interossei. Same thing here. Okay, and I don't know if it was mentioned in the hand talk, but your interossei, their functions, right? I just think of it as pad and dab, right? So dorsal interossei, right? Dab, D for dorsal, dab, AB, right? So dorsal, right? Function is abduction, right? Whereas and pad, right? Your in the hands palmar, right? Or here plantar, right? Plantar interossei, pad, right? Adducts. It's a plantar interossei adducts, right? So it brings back to the midline. Difference, right, is that in the hand, midline, right, in terms of where you're talking about adduction, abduction, the axis is through the middle finger, right? In the foot, it's through the second metatarsal. Yeah, so not the third or the middle. Okay. Any questions on that? Probably, maybe one of the most basic things that we didn't do was even just the bones. But okay, do we have one of the foot?
We
Okay.
might be out of time, Michelle.
Okay, all right, yeah, that's fine.
Probably enough anyway.
Yeah,
These guys probably didn't show themselves.
yeah,
So we,
yeah.
what was the right way around with your thumb again? I thought this was adduction.
I'm pretty sure, because you know your
Yeah.
extensor hallucis longus runs along here, and that pulls it out that way, and then this guy will pull it that way because you've got your.
So this here is extensor. Yeah.
Yeah, so
Yeah.
it extends that way, and then your adductor.
All right, but look
runs-
at this.
Runs down here.
Yeah. So if you
and
think,
so it pulls it that way.
but you just okay. So I'm kind
So
of
if you look at
bony
the
here.
pictures in
Yeah.
Kind of think about what's
This is
abducting and
abduction.
adducting. You got to
Yeah.
think about the anatomical positions
Mm.
of this palms up. So if you're
Yeah.
thinking about whether a specific movement is abducting or adducting from the midline.
Yeah.
Okay, so
So yeah, my
But
understanding.
it's different for the thumb. Like if you look at the pictures in yours, that's
That agreed
Extension.
with the other first, like, 5
Your
images.
explanation is how I learned it.
Flexion.
So do it.
yeah. So that's
Abduction
is away. Yeah.
Is it kind of away from your palm?
Is away
Up.
from the palm.
Okay.
Up.
Is away.
Okay. AB, this is up.
Yeah.
Gotcha. Right. Yeah.
And it makes sense with the.
Yeah. Just look at the tendons, I guess, yeah, on your hand, and you can kind of figure it out as well.
Yeah, flexion and extension.
Was there any questions then on this stuff before I kind of try to put this back together?
Don't worry about that, man. We'll do that. That's what we're here for.
Really? It's
Yeah.
confusing as fuck. Yeah.
Just remember AFA, FA.
Yeah.
Yeah.
And pattern it out.
Have you got to get back to work?
He doesn't get back to
Oh,
Chris is going to kill me.
This goes in there somewhere.
I'm in no rush.
Chris is gonna punch you in the face, just like debut.
Really?
Yeah.
Thanks for coming down.
No worries. Yeah, thanks for letting
I'll
me do it.
redo your certificate
Okay.
because it was like a single A. So I'll get that to you. I'll get that to you by next week.
Yeah, no problem. Hey? Oh no, just making sure I didn't leave it.
we have a sort of heady recognize course.
That's awesome. Yeah.
So
Thanks so much, mate.
No worries.